Welcome to the deep dive. Today we're jumping into some material you sent our way focusing on tissue integrity, wound care, and the whole process of healing.
Yeah, it's a really fundamental topic, understanding how the body puts itself back together.
So our mission here is to kind of unpack this material, highlight the really key ideas, the definitions, the main interventions, so you can get the essentials pretty quickly.
Exactly. We want to make it efficient. We'll touch on, basic skin inflammation, how we classify wounds, the healing steps.
What happens when things go wrong, and even important stuff like how to assess different skin tones properly.
It sounds like a lot, but you'll see it all connects. Maybe we should start right at the surface level.
Okay, sounds good. Let's begin with something pretty common, dermatitis. The material defines it simply as, well, skin inflammation.
That's it in a nutshell. And, how it looks can change quite a bit. In the acute phase, the initial part, you get erythema.
Which is redness.
Right, redness. And often these little seeping vesicles, small blisters with fluid, and of course the big one, pruritus.
Intense itching, a kind that drives you crazy.
Exactly, that's the acute picture.
Okay, so what if it lingers? If the rash becomes, chronic?
Well, if it goes on for a while, especially with chronic scratching, the skin itself changes. It can get thicker. That's called lichenification. And you also often see scaling, like dry, flaky skin.
Makes sense. And the material mentions some nursing interventions here.
Yeah, the key things are obviously giving any prescribed meds, but just as important is teaching good skincare habits and, crucially, helping people figure out and avoid whatever is triggering it.
Avoid the irritants, right. And there are notes on the medications themselves, too.
Yes. Important points.
Yeah.
Antihistamines, like Benadryl for the itching, well, they can make you drowsy. That's a common one. And a really critical point this material makes is about topical corticosteroids. If you use them long-term and then suddenly stop.
Withdrawal problem.
Exactly. Risk of withdrawal. So they need careful management, usually tapering off slowly.
Okay, good to know. So that's surface inflammation. Let's talk about actual breaks, like wounds. This guide really stresses wound staging. Why is that so critical?
Staging gives us a common language. It tells us how deep the tissue damage actually is. And that depth, well, it dictates pretty much everything that follows the kind of dressing, potential complications, how long it might take to heal, is foundational.
Okay, so stage one.
Stage one is interesting because the skin is still intact, the damage is underneath. Yeah. What you see is non-blanchable erythema.
So redness that stays red even when you press on it?
Precisely. That non-blanching part is the giveaway. It shows early damage to the capillaries, not just temporary pressure redness.
Got it. Damage under the skin. So stage two means it's broken through.
Yes. Stage two is a partial thickness loss.
Yeah.
The epidermis, maybe part of the dermis, is gone. It might look like, say, a blister that's burst, maybe filled with serum.
Okay.
But the key thing for stage two is you don't see any fat tissue.
All right. So stage three must be when you do see fat.
Exactly. Stage three is full thickness loss, and you can see the adipose tissue, the fat. You might also see slough.
The yellowish stuff?
Yeah, dead tissue.
Yeah.
Or eschar, which is the hard, black, leathery dead tissue. But, and this is the distinction for stage three, you don't see bone, tendon, or muscle yet.
Which brings us logically to stage four.
Stage four is full thickness loss with exposed bone, tendon, or muscle. Deep damage.
And then there's one more, unstageable, for when you just can't see.
Right. If the wound bed is covered by too much slough or eschar, you physically can't determine the true depth. You can't stage it until that dead tissue is removed or debrided.
Okay, staging gives us depth. The material also talks about drainage, the exudate. Seems like another clue.
Oh, absolutely vital. The type of drainage and how much tells you a huge amount about the wound environment. Is it healing? Okay, is there an infection?
So what are the types?
Well, cellulose drainage is that clear, watery fluid. You often see it early on in healthy inflammation.
Okay.
Sanguineous is active, bleeding, bright red, fresh blood.
And purulent. That sounds like the bad one.
That's the one you watch out for. The material is very clear. Purulent drainage, thick, cloudy, maybe tan, yellow, green, or brown, indicates infection, period. Seeing that changes your whole plan.
Right. And the last one, sanguineous.
That's just a mix. A bit of serous, a bit of sanguineous, so it looks pinkish or pale red.
Okay, so you stage it, look at the drainage, gives you a picture. But how does the body actually heal the wound? The material breaks down the phases.
Yeah, it's this amazing programmed process. It kicks off with the inflammatory phase, first few days, maybe 3 to 6 days. Two main things happen.
Yeah.
Stop the bleeding, that's hemostasis, clotting, and then clean up the mess. Phagocytosis, where cells come in and eat debris and bacteria.
You're preparing the site.
Exactly.
Hmm.
Then comes the building phase, the
Yeah.
proliferative phase. Starts around day 3 or 4, goes maybe up to 3 weeks.
Okay.
This is where the body lays down new collagen, the structural protein, and really importantly, it forms granulation tissue.
We'll come back to that. What's the final phase?
Maturation. This is the long haul. Starts around 3 weeks, but can last a year, even 2 years sometimes. The collagen gets remodeled, reorganized, stronger. The scar tissue matures and shrinks a bit.
You mentioned granulation tissue back in the proliferative phase. The guide describes it quite vividly.
It does, and it's a really helpful description. Granulation tissue is basically the new foundation being built in the wound bed. It's described as fleshy, pink, or red, moist tissue. It's full of new tiny blood vessels,
And these
deep pink or red, and it has this irregular, bumpy surface. The guide actually says it looks like raspberries.
like raspberries. That's memorable. And seeing that raspberry tissue is a good thing.
A very good thing. It's a strong visual sign that the wound is in that active building phase, the proliferative phase. It means healing is progressing, especially if the wound is filling in from the bottom.
Right, which ties into how wounds close, the different intentions of healing.
Yeah, basically 3 main ways, depending on how the edges are managed. First, intention, or primary intention, is your typical clean surgical cut. The edges are brought right together, approximated with stitches, staples, glue, whatever.
Heals fast, minimal scar.
Exactly. Because there's not much of a gap to fill.
So second intention must be when it is left open and where that granulation tissue comes in.
Precisely. Second intention is for wounds left open, maybe large wounds, pressure injuries, burns. They have to heal from the base upwards by filling in with all that granulation tissue we just talked about.
Takes longer, bigger scar?
Generally, yes, much more tissue needs to be rebuilt.
Okay. And third intention.
Third intention is like a delayed primary closure. The wound is deliberately left open for a while, maybe to clear infection or let swelling go down, and then it's surgically closed later on. Kind of a hybrid approach.
Gotcha. Okay. Thinking about those surgical wounds, first intention healing.
Hmm?
The material mentions wound drains. Why put a drain in?
Good question. Drains are basically there to stop fluid, like blood or serum, from building up under the incision. If that fluid collects, it creates a space, which is perfect for bacteria to grow.
Leading to infection.
Right. Or the fluid pressure can push the wound edges apart, stopping them from healing together properly. So the drain removes that excess fluid, helps prevent infection, and lets the edges approximate nicely.
Makes sense. And there are different kinds mentioned here.
Yeah, a couple of main types. There's the Penrose drain. That's an open system. It's just a soft, flat, flexible tube. Fluid drains out passively onto a dressing. You usually see a safety pin stuck through the end that's outside the body.
Oh, yeah. Why is that?
Crucial. It stops the drain from accidentally slipping all the way back inside the wound.
Ah, smart. Okay, and the closed systems?
Those use suction, like the Jackson-Pratt drain, the JP drain. It's a tube connected to this soft, compressible bulb. You squeeze the bulb, put the cap on, and as it tries to expand back, it creates gentle suction.
Pulls the fluid out.
Exactly. The Hemovac is similar, another closed system, but uses a sort of spring-loaded cylinder device to create the suction. You see those more when you expect a bit more drainage.
Okay. So we've got the healing process, drains to help, but sometimes things go wrong. The material highlights 2 big complications: dehiscence and evisceration.
Yeah, these are serious problems. Basically, the wound comes apart after it's been closed. Dehiscence is when a surgical incision, for example, separates. The edges open up. You might see underlying tissue like fat or maybe even muscle.
Okay, that sounds bad. But evisceration sounds even worse.
Evisceration is a true medical emergency. It's when the wound opens up completely and internal organs actually protrude out of the body cavity.
Wow. That's, an emergency. The material lists some shared risk factors for both.
Yes. Things that interfere with healing or put pressure on the wound line, like obesity, poor nutrition if the wound gets infected.
Makes sense.
Or things that cause sudden strain, like really forceful coughing, vomiting, or straining.
Right. And the immediate actions are different, especially for evisceration.
Very different. For dehiscence, the wound opening, but no organs out. The guide says cover it right away with sterile dressing soaked in sterile saline and notify the surgeon.
Okay. But for evisceration, the organs are out.
For evisceration, time is critical, and the steps are specific. First, get the patient into a low Fowler's position, semi-sitting, knees slightly bent. That helps reduce the strain on the abdomen.
Okay, I reduced pressure.
Second, immediately cover the protruding organs with sterile dressings that are kept constantly moist with sterile normal saline. You must keep those organs moist and protected. Don't let them dry out.
Got it. Moist, sterile dressings.
Then, notify the surgeon immediately. While you're waiting, monitor vital signs, constantly looking for any signs of shock. And prepare the patient because they're going to need emergency surgery.
And there's one absolute don't mentioned.
Yes, a huge point. Do not try to push the organs back in. Just cover them, keep them moist, and wait for the surgical team.
Okay, critical steps. We've covered general wounds, complications. The material also specifically mentions amputations.
Right, which is obviously a planned wound, a significant tissue disruption. It mentions different types based on the situation. A close amputation is when they create skin flaps and close the end of the residual limb right away during the surgery.
And open amputations?
Those are sometimes called guillotine amputations. They're done specifically if there's infection already present in the limb. The end is left open intentionally.
To let it drain.
Exactly.
Yeah.
To allow drainage and manage the infection. It heals by second intention, remember, filling in from the bottom with granulation tissue, and then it's usually closed surgically later on, once the infection's clear.
Ah, connects back again. And after amputation, stump care is key. Compression bandages.
Yeah, applying a compression bandage right after surgery is important for a couple of reasons. One, it helps control swelling, the edema. Two, it helps shape the stump into that kind of conical form needed to eventually fit a prosthesis.
Okay.
And the guide notes these bandages need to be taken off and reapplied regularly, maybe 3 or 4 times a day, to keep the pressure right and check the skin.
We've spent a lot of time talking about looking at wounds, drainage, tissue. This material brings up a really vital skill that's broader than just wounds, but essential here. Assessing skin tones, especially in darker skin patients. Why is this so important?
It's absolutely critical because some of the key visual signs we rely on, like redness, erythema from inflammation, or pallor, paleness, indicating shock or cyanosis, that bluish tint from low oxygen can be much harder, sometimes impossible, to see directly on darker skin.
So relying just on color changes might mean you miss something big.
You definitely could, so you have to know where else to look.
Where are those places?
The material points out areas where the underlying blood flow changes might be more apparent, or where there's less pigmentation. So check the mucous membranes inside the mouth, the lips. Look at the palms of the hands and the soles of the feet. Check the nail beds and the sclera, the whites of the eyes.
Okay, those specific spots. And comparing sides is important, too.
Essential. Always compare the area you're concerned about with an unaffected area on the same person. Look for subtle color changes, sure, but also feel for differences in temperature or skin texture. That comparison can be crucial.
Wow, okay. We have really covered a lot of ground, haven't we? From like a simple rash all the way through the stages of healing, major complications, even amputations, and these vital assessment skills.
We have. And what's striking is how interconnected it all is. You see how, say, a problem in that proliferative, that building phase of healing can lead directly to something serious like dehiscence.
Right.
Or how understanding staging and drainage helps you understand why you'd use a drain for one type of wound but not another. It all fits together.
It really highlights how important careful observation is. Knowing what tiny detail to look for the color of drainage, the texture of tissue, where to look on different skin tones gives you so much critical information.
It really does. It shows the body's amazing capacity to heal, but also its vulnerabilities.
What's maybe one final thought that occurs to you from all this? I guess it's just the complexity hidden in plain sight. Healing seems simple, maybe, but underneath, it's this incredibly orchestrated process. Every phase, every cell type, every sign we talked about, it's all part of this intricate biological repair system.
Yeah, and understanding those fundamentals is just so key for recognizing when things are going right or when they're starting to go wrong. It really makes you think about how much information our bodies are constantly giving us if we just know how to look and listen.